Now we have none other than Professor J.S. TITIYAL. We all know he's an excellent academician, excellent surgeon. Now he's taking the Apex institution with his academic capabilities also. And he's going to be talking to us about optimizing ocular surface perioperatively. Being a superb cornea surgeon, as well as a cataract surgeon and a refractive surgeon, I can't think of anyone else who can cover this topic more optimally. Over to you, Professor.
Thank you, Dr. Ramamurthy, sir, and good morning, friends. You heard so many talks on today's session. One thing which is, real, you can say, bother as far as the patient is concerned and the surgeon is concerned is the symptoms of patient. And you all do cataract surgery and you have done a perfect surgery and patient not happy. And that is a scenario so difficult to make him understand what is wrong in his eye and what should be done, why he's having that problem of watering and itching and irritation and foreign body sensation. I think these are 3 or 4 words which really kills your morning when patient comes back to you. 6 vision and he's not happy. So there is importance of this particular talk where we need to look into ocular surface of all our patients who are coming for cataract surgery, and it has a very, very significant importance in managing cases of cataract surgery patient coming. We know that large number of patients may be suffering from a dry eye disease or some sort of ocular surface disorder, and they are asymptomatic. And we all understand we have to follow a routine where you pick up these patients as such. If you look into recommendation from American Academy Preferred Practice, ACRS, they'll say always look for a ocular surface disease in your patient before cataract surgery. That is what we also do. Every patient of cataract surgery, I ask my resident to put 1 drop of fluorescein and see what happens to ocular surface, and that will decrease the problems. If you see here, almost hardly few patients will come pre-op having some sort of symptoms. Only 1/5 of patients have a symptoms of dry eye when you actually ask them. But if you examine these patients, almost 60 to 80% patient will have a dry eye features. So that is a very significant point because that has an impact onto your outcome in your patients. So this unhealthy ocular surface or unhealthy tear film has so much of importance to look into. It can give you, as Dr. Chitra was talking about, inaccurate keratometry. Your entire IOL power calculation may not be appropriate for that particular patient, especially if they are coming for a multifocal or a trifocal lenses, and they'll have a suboptimal visual outcome subsequently. And there'll be a need for enhancement, which Dr. Chitra was talking about. Subsequently, you realize you have done a mistake in these patients. Most importantly, a poor quality of vision and patient unhappiness is because of ocular surface most of the time. Patient coming back to you with the halos, a poor vision, we think of posterior capsule first. We never think of ocular surface. So there's an importance of seeing, examining, and investigating your patient ocular surface, especially for our premium IOLs. Other important thing is after surgery, the dryness or ocular surface is going to deteriorate, and patient will be very, very unhappy in these patients. So we need to look into incisions, the toxicity which can happen on the table, look for inflammation which may be contributing the increase in the dry eye features in the patient, look for a Meibomian gland dysfunction, and if needed, change your post-op medication to improve these patients. Therefore, we need to identify patients with dry eyes or high-risk patients, treat these patients before surgery. Surgery in cataract nowadays, almost 90% of cases are elective surgery. So you can wait, you can treat the patient and plan subsequently. A patient who may not be fit for a multifocal lens, after treatment, he may be, you can still give him the opportunity of a trifocal lens in these cases. Intraoperatively, make sure you don't damage the ocular surface. And in post-op, most importantly, use steroid cautiously. And if you are using anti-inflammatory medications, that should be preservative-free. Some patients require a glaucoma medication. Always now we see a lot of glaucoma medication are preservative-free. That is a very important aspect. In pre-op, I think history taking is very, very important for our patients. Look We don't ask them, in fact, and they come with the watering and itching and irritation a post-op period. One question you should always ask your patient: do you have watering, pain, redness, irritation often on your case? Are you putting any artificial tears? Because that's going to guide you if patient would have a ocular surface disease. Especially patient with anti-glaucoma medication, you should be very, very careful. Or patient who has a diabetes or undergone laser treatment, this is very, very important thing to look into. And more importantly, these are old patients. They may be having arthritis, systemic disorder, disease, which should be also noted and recorded in these patients. Investigations, you all know, we are looking for ocular surface. So TBUT and staining is very important for your patient. Look for a surmas which may not be very accurate, but sometimes a patient are poor surmas, that is a indicated patients are dry in these patients. Tear osmolarity may not be available to most of us, but it can be done. Mammography nowadays can be done very effectively. Look for a meniscus, because that gives you a lot of information, the height, the debris, all these things are important. See, this is a one important investigation. Sometimes your optometrist or a person who is doing investigation tell you that patient doesn't have a good ocular surface by just looking into keratometric Myers, or if you look into a telecentric Myers in your IOL master, he can tell you that this patient has an ocular surface disease. If you see this particular case, looks quite normal. You put a fluorescein, see how many surface, punctate staining patient has. Sometimes you have a conjunctival calluses, which may be the cause for a poor patient's outcome in these cases. Examine conjunctiva also very appropriately. See this inflammatory mark in these cases. MGD is another important area which should be looked into. If you have gadgets, you can look into tear film, lipid layer thickness, and the Meibomian gland. That is very important. You can treat them. So what should be goal for our patients? We can treat them in a manner which decreases the aberration and improves the functional visual outcome, and that is going to decrease the symptoms of patient in these cases. So these are various treatment modality we have. Artificial tear is a mainstay of management for all dry eye patients. Holds true for cataract patients also. We can, especially patient with an inflammatory dry eye, we can use steroids, or we can use cyclosporin in these patients. Punctal occlusion is not desirable as such. Unless the patient has surmas which is less than 5, and your patient is going to have severe punctate stainings, you might think of this along with the anti-inflammatory in these cases. And after surgery, if patient improves, you may have to remove. So always go for a, which can be, temporary punctal plug should be done in these patients. Blepharitis, lid margin examinations are very, very important in these cases. And this is the various ways you can treat your patient as such. Intraoperatively, you know that if you do incision appropriately and place the viscoelastic over the cornea, you're going to damage less epithelium. Never use topical medication excessively in these cases of dry eye patients. That is going to actually create the problem in these patients. Size-wise, this is one controversial statement. SICS patients have more dry eyes than phacoemulsification, which I don't feel correct, but this has been reported in the literature as such. So dry eye as such after surgery may enhance within the first 1 month or 3 months, and slowly within 6 months dry eye settles down to most patients with treatment. But there are certain percent of cases dry eye never settles down. So this is one of my patient, day 1 after beautiful cataract surgery. You can see a thinning happening in the area where you have a conjunctival bogginess. So this is called Dellen. And if you see the stain, there's a pooling here. In such cases, ocular surface management is very appropriately. If you don't manage that, there'll be a melting and you may have a perforation also. The lubrications, if needed, contact lens, soft contact lens for a few days should be put. If there's a thickening of a conjunctiva, pterygium should be tackled appropriately also. This is one case example of one of my patients where I put multifocal IOLs. Patients are not happy with 6.6 and N8 vision, poor very quality. Now this is what staining showed, a lot of punctate staining, and the wavefront aberration was huge in this patient. So we treated this patient as we described the artificial tears, especially sodium hyaluronate as one of the important combination there. Nighttime gel and cyclosporin for 3 months. Now after 3 months, patient improved significantly. So this is a significance that any patient who has symptoms, make sure you stain the cornea, stain the ocular surface, rule out dry eye in these cases. To summarize, all cataract patients can undergo dryness, Before surgery, they may have almost 60% of cases have a dry ocular surface, and after surgery, they also increase and create a lot of problem for us. The counseling can also be very important aspect for these patients. If possible, use preservative-free medications. Unfortunately, steroids don't come in a preservative form, but it should be available very, very soon, and counseling will be very important for these patients. Thank you for your kind listening.